My name is Ed Johnson, and I am the Associate Director of Training and Technical Assistance at the Southeast Addiction Technology Transfer Center, which is located at the Morehouse School of Medicine at the National Center for Primary Care at Morehouse School of Medicine. And we'll go over a little bit more about ATTC and all that stuff in a little bit. Some housekeeping things as far as for the presentation. We can, depending on how many folks are here, I'll be switching back and forth between, like right now, and the actual PowerPoint presentation. If you have a question, if because I want to say there was like 40 some odd or 50 some odd folks that signed up, we'll use the chat box feature, and I'll do my best to keep track of it. Otherwise, you can raise your hand and unmute yourself, and you're welcome to ask a question. One of the things too, to let you know, is at the end of the presentation, we will have a link to a post-webinar evaluation for those of you that might be familiar with SAMHSA and SAMHSA's love for bureaucratic paperwork. I can't believe I said that, and we're being recorded. The GIPRA, it's specifically, it shouldn't take you very long to fill out. Once you complete it and send it in, then that will trigger getting your CE certificate out to you. So you need to make sure that you take time to fill out the evaluation, because that's what's going to get you the CEs for 1.5 hours, which I know is probably, while I'm hoping y'all are here to find out everything you wanted to know about contingency management, but if you're just here for the CEs, that's okay too. That's one of the deals. Like, I do ethics trainings, and I'm perfectly okay with, like, I gotta renew my license, I need ethics trainings. Like, okay, fine. Is there anything else, Michelle? Any other housekeeping kind of deals? Okay, I didn't think so. So let us get started here. A little bit more about me, because I don't know about y'all, but one of my personal things is I like to know a little bit about the person that is talking. I have been here at the ATTC for about 11 years now. Prior to that, I worked at Charleston Center, which is the Charleston County, South Carolina Department of Alcohol and Drug Abuse Services. And I worked there for about 20 years, a little over 20 years. I managed the last 10 years, I managed the HIV Early Intervention Service and the Opioid Treatment Program. So one of the things that I'll go ahead and mention now, what we're going to be talking about is based on a study. Now, granted, there have been multiple studies of contingency management, but the National Institute of Drug Abuse, through their clinical trials network, did a study specifically looking at the use of motivational incentives, which is another term for contingency management. And there were two arms to the study. One arm was a drug-free arm, and basically the people that were in that arm had to have a diagnosis of course, at the time, it was stimulant dependence. And then the other arm was restricted to people who were on methadone maintenance, but also, in addition to having problems with opioids, also had issues with, had a stimulant dependence diagnosis. So one of the neat things about it was that my program, the OTP that I managed, we were one of the sites for the opioid treatment arm, and our women's services were one of the arms for the drug free. So it's not just theoretical. I actually, had fun watching it work, and then we continued to use it after that. Which we'll talk about that as we're going through. One other thing, which I always like to point out to folks as we go along in something like this, I'm also a person in long-term recovery, which for me means that it's been almost 37 years since I've used any alcohol, illicit, or non-prescribed medication. So, today my life is about recovery, and I'm one of those people who's firmly convinced that recovery is a gift that anyone can have. It's not a matter of figuring out how you get them into treatment as much as it's a matter of figuring out what does that person need to support their recovery within their own community. Okay. So with that, we will move along. And again, like I said, if you have any questions as we're going along, I might not remember to ask. Please feel free to just jump in and ask. All right. So I use as a title for this more carrot, less stick, because basically contingency management or using motivational incentives fits in the category of operant conditioning. Okay. So you're using incentives or contingencies to affect the behavioral change as opposed to using other other means to achieve behavioral change. Some things to point out here. This is my email, and towards the end, I will type it into the chat box. And also, this is our website at that you can go to and see all sorts of stuff that we're doing at the Southeast ATTC. And one of the things, we are funded by SAMHSA. And so we like to help folks become aware of the different kind of services that SAMHSA provides, one of which is there are three different types of technology transfer centers that SAMHSA funds. The purpose of the technology transfer centers is basically to develop and strengthen the workforce, be it in overall behavioral health, substance use disorder, and mental health disorder prevention, treatment, and recovery support services. We want to help people implement evidence-based practice. In other words, not just stuff that fits in the category of, yeah, we've been doing this for 30 years and why should we change now? And we'll talk a little bit about that mindset when we actually get into talking about motivational incentives or contingency management. There are three. You've got the addiction technology transfer centers, which is what we are one of, that have been around for about 26 years. About 2 years ago, SAMHSA decided that the ATTCs were a pretty effective model, and so they basically created, along the same lines, mental health technology transfer centers and prevention technology transfer centers. And again, the focus of each is implementing evidence-based practices and improving the effectiveness of the workforce in those two areas. Now, each of the ATTCs is comprised of 13 centers. You've got 10 regional centers, which is what we are one of in each network. And then you have 2 specialized centers, one that is specifically focused on American Indians and Alaska natives, the other on Hispanic Latino, folks, and then each of the networks has a coordinating office. And this, while it might be a little challenging to read, I included this primarily. You can see the Southeast region here, and basically, we, as in the Addiction Technology Transfer Center, we are located at Morehouse School of Medicine. The Mental Health Technology Transfer Center is located at Emory University in Atlanta. And then the Southeast Prevention Technology Transfer Center is located at Wake Forest in Winston-Salem. And if you were to go to ATTCnetwork.org, to that website, that will allow you to, or TTC network.org, it will allow you to go specifically to the pages of all of those different websites, depending on what region you're in, and it'll ask you. So for those of you that might not be in the Southeast, you'll be able to hook into your specific area. What SAMHSA had in mind was that the American Indian and Alaska Native and the Hispanic Latino centers would serve specifically as subject matter experts in working with those two populations, be it with respect to mental health prevention or addiction. They also provide specific population-related support to the regional centers. So if you're interested in finding out, best practices and things specific to working with those two populations, they are, again, you can access them through the national website. And again, the national offices are basically, to help coordinate, so there's not a, duplication of effort. Now, here is us. Here at the Southeast, we basically provide services in the states of Alabama, Florida, Georgia, Kentucky, Mississippi, North Carolina, South Carolina, and Tennessee. Periodically, because we are subject matter experts in certain other things, we provide services outside of our region if we get called upon by another regional center. And so again, and this is something I always like to toss out. Even though we're based in Atlanta, I need to share with you all the fact that I am the most remote employee of the Morehouse School of Medicine. I'm actually located in Charleston, South Carolina, because when I originally started here, instead of covering all those 8 states, we only covered North Carolina, South Carolina, and Georgia. And North Carolina and South Carolina had program managers in the individual state. And since I'd been in the system in South Carolina for 20 years, that's it. So now I am the most remote employee, which is pretty cool. Because Atlanta was, when I was an undergraduate at Auburn University a long time ago, Atlanta was moderately amusing for weekend entertainment, since there wasn't a whole heck of a lot going on in Auburn, Alabama. Traffic was horrible back in the early 70s, and it hasn't gotten a whole lot better since then. So that's why I'm perfectly content to be over here in Charleston. So one of the things, briefly, and I include this in all of the presentations that I do, I'll be honest with you, is to stress the fact that that the language has a very big impact. I think all of us on this call are more than aware of the fact that substance use disorders have a significant amount of stigma attached to them. And as a result of that, people who have substance use disorders are on the receiving end of a fairly significant amount of discrimination. One of the things that's important to understand, though, is that by the language that we use as professionals, and a lot of other behavioral and medical health professionals use, we perpetuate a whole lot of that stigma unknowingly. We just do. And it's one of those things that for so many of us, we've used words and phrases for so long, we don't realize that, oh, that's what the general population thinks when we use that term. So some things to be aware of. And we're, again, um, there is, um, and I can send you, if you're interested, I can share with you a specific handout that has this in it. But there are two things that probably do more damage than anything at all. The biggest one, I'll be honest with you, is this term substance abuse or drug abuse or prescription drug abuse. Primarily that is, and I mean, this is something to think about. Um, you know, we all talk about the fact that, you know, substance use disorders are a medical condition, but a lot of the terms we use are not medical. They just aren't. And substance abuse is one of those that is not a medical term. Abuse is not a medical term. Um, and especially now that we're using DSM-5, it's not like there used to be dependence and abuse diagnoses. Now it's substance use disorder. So there's no reason that needs to be in there. And the problem is that the general public, when they see substance abuse, they put it in the same category as domestic abuse or child abuse, which I think, y'all would readily agree is not a really good neighborhood to hang out in. One of the deals too is that, again, it's not accurate because, think about it. Child abuse, perpetrator abuses children. Domestic abuse, perpetrator abuses their partner. I got to tell you, I mean, I'm going to be totally honest with you. Before I got into recovery, I absolutely positively did not abuse my substances. I took exceptionally good care of my substances. My substances might have done bad things to me, but I took really good care of them. The deal with probably the next problematic one is not using person first language, and by that, and I'm just going to toss this out. Because a lot of times hearing people when I'll bring this up, people will make the statement about, oh, that's just being politically correct. Well, maybe this is just me, but I tend to look at things that sometimes are pigeonholed as being politically correct as common courtesy. And, as somebody who is in recovery, there's a whole lot more to me than just having a substance use disorder. So, I am a person. There's a lot more things that contribute to making up who Ed is, other than the fact that he has a substance use disorder. Um, and it's important. One of the deals too that a lot of times people say, well, I use the term recovering addict or recovering alcoholic. Well, again, the problem with that is the general public, when they don't hear that recovering. All they hear is alcoholic or addict. So that's why, if you noticed, I use the term person in long-term recovery, because using the term recovering alcoholic, the general public's like, oh Lord, he's going to bust out drunk anytime now. I mean, one of the stories that I love to share is it was right before my grandmother was going into an assisted living facility over where she lived in East Texas. And this is a woman who, maybe would have one Southern Comfort and Coke around the holidays and would only drink half of that. Never could figure that one out. A, why she drinks Southern Comfort, but B, why she only have half of it. But we were getting ready to take her, and one of the joys of people that are a bit older than I am is that they think that they have trouble hearing, so everybody else must have trouble hearing also. So they sort of have a little bit of a loud voice. I heard that once referred to as the Irish whisper. Um, and so I hear my grandmother talking to my aunt, says, "Now, Doris, when Ed leaves to take me out to Cartmel, what I want you to do is there is a bottle of Reese's cooking sherry in the refrigerator. And I want you to take that out and pour it down the drain so he's not tempted when he's here at the house by himself tonight." And of course, she padded back to her bedroom. And I looked around the corner at my aunt and I said, "You do realize that I've been in recovery for 17 years now. And if I'm going to start drinking again, it surely is not going to be with Reese's cooking sherry that's probably already turned to vinegar." And she looks at me and goes, "Oh, well, I know, honey, but you know how your mamaw is." And it's like, yes, yes, I do. Um, so, these other terms here are also things to be aware of, that, and probably, again, some of the worst also are referring, and a lot of times people who, when they get into recovery, they refer to themselves as clean and sober. Well, if you're referring to yourself as clean when you're not using addictive substances, that mean when you were using addictive substances, you were dirty? That's not something that you would, I mean, and again, to deal with urine drug screens. I mean, if you ever, ever, ever had blood work drawn at your doctor's office and gone in to get the results, and the doctor looks at you and goes, "Well, blood work came back dirty. You're dirty for cancer." It's like, no. So it's like, it's either positive or negative, and it's important to remember that. Their urine drug screens are, you know, they're medical tests. So, moving right along. So our words do matter. Some things we hopefully y'all will leave with today is that you'll will increase your knowledge as far as how contingency management or motivational incentives, and I use the terms interchangeably, enhance treatment outcomes and facilitate patients getting into recovery. And when I say enhance treatment outcomes, I'm basically referring to the fact that they can enhance patients being engaged in therapy, also with respect to decreasing the frequency of positive drug screens. We're going to talk about the NIDA clinical trials network study that provided the basis for this. We're going to look at some specific behavioral terms and definitions that sort of apply to all this. And we're going to talk about one specific method of using contingency management. It's referred to as the fishbowl method, which is something that y'all will actually, you could actually apply. Okay. So again, like I've said, I tend to interchange contingency management with motivational incentives, so they mean the same thing. All right. So just so you don't get confused, um, the whole purpose of motivational incentives, the whole purpose of contingency management is to enhance treatment outcomes and facilitate recovery. But more importantly, as part of that, you're wanting to target specific behaviors that you want to facilitate change with that show up on the patient's treatment plan. So there are multiple different things you can use this for. One of the deals too that's important about using motivational incentives is, and I think all of us that are familiar with doing treatment plans or plans of care for the folks that we work with, you want to set the goals low enough or attainable enough so that you can have small successes. Because again, I think all of us are aware of the fact that, the more positive changes, the more positive outcomes that somebody we work with has, it sort of provides increased motivation for continuing that. And so that's one of the deals with this, that you're celebrating that person's success. And one of the things, and I'll point this out later on too, A lot of old school counselors have a problem rewarding these individual successes because the statement that gets made on a routine basis is, why in the heck should you reward them for doing what they should be doing anyway? My philosophy with that is, who the heck cares? I mean, the bottom line is they're changing the behavior. Doesn't matter. It's like, why are we doing this? To be stinkers or to facilitate change? Um, and one of the deals that I'll share with you is, a lot of times after getting involved with it, even the ones that say that get caught up in it. So it's like, even the old silverback gorillas that have been in the field since Bill Wilson was drinking can come around. So some things that are important to remember about this whole thing is that motivational incentives or contingency management is not a standalone intervention. It's an adjunct. Okay, it's an adjunct to therapeutic clinical methods. It can be used throughout the various stages of change. It just is going to depend on the way it needs to be tweaked. Is, what is the incentive? And the thing is, the bottom line is, you want, the whole purpose is to reinforce the changed behaviors. Okay, that's what you want to do. That's where the stick comes in. All right. Um, okay. So, and of course, the ever popular stages of change. One of the deals, and obviously, I mean, well, not obviously, but probably the most effective, at least from my perspective, and having worked with folks in opioid treatment, a lot of times when we would get patients that would come into services, um, they acknowledged that they had a problem with opioids, but if they were misusing any other substances, they weren't a problem. So the challenge was, and then once they got stabilized on medication, it's like, nah, I don't need counseling. I'm doing fine. Because the motivation was they didn't want to get sick anymore. Um, so the challenge was to get those folks engaged. Okay. Um, Motivational interviewing with this group of people was wildly effective, because again, cognitive behavioral therapy is fine if the person is already, either at the action phase, or at least acknowledges that they've got a problem. Well, it's not too good with somebody who's at the pre-contemplation stage. So a lot of what the focus of what we're going to be talking about has to do with these folks in pre-contemplation and contemplation, as far as how to get them engaged, and get them moving further up the stages of change. Okay. Um, and of course, this is what we're going to talk about. And, one of the deals too, that a lot of times questions that come up is, okay, we don't have a whole lot of money. So how are we going to do this? Because originally, well, and I'll just go ahead and mention it now. I mean, probably the first time this methodology was used was quite a while ago, and it was done in the VA, and they offered cash incentives. And I mean, they were pretty substantial cash incentives. So it's like, I mean, other than the fact that I think all of us would agree, if you work with folks with substance use disorders, giving our folks cash is not a real good idea. It's one of those deals. It's like you're almost setting them up. And that particular study, while it achieved some good outcomes, it was way too expensive to replicate. So that's where some additional studies looked at it. So and also we're going to look at the for those of you that are frontline or middle management folks in treatment organizations. we're going to look at from the perspective of if you're trying to convince the administration at your agency why it might be a good idea to do this. We're going to give you some reasons as far as, again, based on research, as to why this might be beneficial for them to implement, and why it might be beneficial to maybe carve a little bit of money out of the budget to implement this. Okay, so it's important to get it that what we're talking about here is that the incentives are basically reinforcers, and they can be anything from vouchers for services. They can be gift cards. They can be privileges. They can be any number of different things. It just depends on um, what your agency wants to do, and how they want to structure it. Um, a lot of times, and this is, some of you might be thinking right now, we don't do that. But any kind of reward or acknowledgement that you give to any of your patients or clients, that for something they do, that's a motivational incentive. That's a reward. But the problem is that usually we only give those to people who are already motivated. We don't give them to folks who we're trying to get motivated. Which, I'll be honest with you, one of my pet peeves, and by the time we're through together, you'll realize that it has a whole bunch of pet peeves. Is that we use the statement a lot in substance use disorder treatment. It's like, well, they need to be motivated when they get here. And it's like, well, the bottom line is, no, they don't. They just need to get here. It's our job to motivate them. Okay. It's our job, by the therapeutic interventions that we have all those letters after our name that makes us able to do, that help out with that. It's like another one of my peeves is that when a clinician uses the phrase, it's like, I can't do anything with that person. They're just in denial. Well, my feeling about using that phrase is it's a cop-out. It's sort of like a teacher saying that child in my class is too stupid to learn. It's like, no, how about maybe looking at it from the perspective of how can you present that information to that child to where the child will learn? What's the barrier to that child learning? And for us as clinicians, it's like, what is the barrier that is keeping that person from being able to get into and sustain recovery? And I think all of us know that a big part of that barrier for a lot of the folks we work with is trauma. Now, something to think about is, and this has to do with directors, is that providing them, and we'll get into more specifics about this, but increasing patient motivation. Why in the world would that matter? Well, if the patients are motivated, they're more likely to stay in treatment. It's the same way of, I don't know if any of y'all are familiar with what are referred to as perception of care studies, as opposed to satisfaction surveys. Perception of care surveys basically look at things like, I feel like my treatment program is supporting of me in recovery. I feel like my counselor listens to me, and is that my counselor supports me getting into, it's basically looking at it from the standpoint of, does that person who's in, who's the patient or client, do they feel like that you really give a rat's behind about them getting into recovery or not? And it's one of those things that it has been demonstrated clearly that if the client has a positive perception of care, they're going to stay in treatment longer and they're going to have better treatment outcomes. Okay. Um, one of the deals too about motivational incentives is that it does improve the attitude and morale of the staff. Because stop and think about it. How many folks, um, I mean, granted, it was a long, long time ago. Um, when I was a frontline clinician, it can get real challenging sometimes when you've been working with somebody and you thought they got it, and all of a sudden they get a positive drug screen. And it's like, and even though, you get told on a routine basis, it's like, it's not your fault. You know, you still internalize it. And that gets a bit discouraging sometimes. It really does. So it's like anything you can do to help keep because again, a motivated counselor or a counselor with a positive attitude is going to have a heck of a lot better outcomes than one who's, Dolores Doom or Georgianne Grinch. That's not going to work real well. And this is something, and I'm just gonna, I need to point this out right at this particular moment. Back in 2008, the Inspector General at SAMHSA, at the Department of Health and Human Services, issued an opinion that no, using motivational incentives was not that was not bribery, and it was okay to use it. Well, unfortunately, the most recent, and I think they're still in office, Inspector General came up with a completely opposite opinion, that not that it was bribery, but it fit into the category of kickbacks, which is like, so SAMHSA placed very significant limitations on what their funds could be used for with respect to motivational interviewing. They're working very hard on getting that opinion changed. And my sense is that the current acting Assistant Secretary for Mental Health and Substance Use Disorder Services, who's very much in favor of motivational incentives, is going to be lobbying for that. But just to where so, this again stresses the fact this is an adjunct. It's another clinical tool that you can use to move somebody in the direction of, because think about it, one of the biggest challenges for people who are early or in the pre-contemplation stage or even in the contemplation stage is getting them to get it. And I mean, this is one of the deals with motivational interviewing, helping that person get it, that with MI, that what they're wanting for their life, but is different than what they're doing. What they're doing is not going to get them where they want to go, and getting them to realize that. And the deal is with contingency management or motivational incentives, what the deal is that by facilitating periods of time when, say, for example, that individual who didn't think they had a problem with their cocaine use or their, other drug use, you've gotten them to go for a period of time without using those drugs. And hopefully you can help them make the connection between their life being better or different and the drugs and alcohol or whatever the other substances were not being present. So they will get it that, maybe my life is better without those things that the counselor mentioned before. So again, that's one of the deals. Let me see here. And again, if you have any questions as we're going along, please, please, please don't hesitate to, put something in the chat box, because I do periodically check it. Now, I think everybody is aware of classical conditioning, Can you say Pavlov's dogs? So that's not what we're talking about here. That is not, absolutely not what we're talking about. What we are talking about is operant conditioning. In other words, we're talking about a voluntary behavior that when it is performed, there is a consequence. Now, there are, what we're going to be talking about is positive reinforcers or positive consequences as opposed to negative consequences. We'll explain that in a second. So the deal is, you know, and what we're not going to be talking about punishment, even though the whole deal with punishment is to cause the specific behavior to decrease. That's the stick. Okay. And I think all of us are familiar with, you know, that kind of motivation. And years ago, I was doing a training on screening, brief intervention, and referral to treatment, and you know, talking about motivational interviewing. And there was a person in the class who worked with criminal justice programs, and he basically, and he'd been working there for a long time, you know, made the observation, it's like, I don't care if they are compliant, or they're you know, have a positive motivation to change. I just want them to be compliant, to do what they're told. So I said, okay. I said, so let me ask you this. How many people do you have that have been through your program that show back up in your program again after they've been quote unquote successfully discharged? And he sat and looked there and he didn't say anything. And I said, if you got buy-in from those people the first time, they would continue that behavior after they were discharged from treatment, as opposed to reverting back to the behavior that they had engaged in prior to and coming into treatment. And it was almost like I saw a glimmer of a light bulb come on, but wasn't quite sure. So anyway, again, what we're talking about is we're looking to increase specific behaviors, and we'll go into that a little bit more. You know, we are definitely, and of course, one of the things that I love about this, and I know I'm dating myself by pointing this out, for those of you that might be a bit younger, the thing that this picture is of is a chalkboard. It's not a dry erase board, and this is a piece of chalk right here, okay? And if you really got in trouble when you were in grade school, you usually would end up having to do something like this, or clean those those chalkboards before you could go out for recess. Okay. Just thought I'd share that with you. A little flashback, little throwback Thursday for you here. You know, what we're talking about, what punishment involves is an adverse stimuli. Okay. Whenever, if you want to think of, you know, shock therapy or something like that, you know, that's an adverse stimuli. Now the deal is, with when we're talking about reinforcements, what we're talking about is you've got positive reinforcements, which is what we're going to spend our time talking about, which means that somebody gets something positive when they engage in the desired behavior. So they get a reward, they get an incentive. The deal is now with negative reinforcement, that involves removing the negative stimulus when the desired behavior happens. Okay, so some examples of that would be, with respect to positive reinforcement, you know, if you go to work every day and do your job, guess what's going to happen? At regular intervals, you are going to get a paycheck. That is positive reinforcement. All right. Negative reinforcement is, you know, mom is always screaming at her teenager to clean up your room. You're not going anywhere until you clean up your room. Well, when the teenager finally does it, mom stops yelling at him. Okay, so the negative stimuli goes away when they engage in the desired behavior. Okay, and so we're not going to be talking about this. We're just going to be talking about positive reinforcement. All right. Those of you that are familiar with 12-step programs are probably aware of the CHIP system. Okay, which basically, depending on certain amounts of time in recovery, somebody gets a different chip to mark that milestone. And even though it might not be a big deal to some people, I know from my perspective, back in the first year of recovery, it was a big deal. It didn't seem like much, but it was a pretty darn big deal, because everybody else would make a big deal out of it, and they would clap and they would congratulate me, and it was almost like, wow, these people really do like me, and they want me to be successful, and they're here to support me doing that. Those are the kind of things that's what we're talking about here. Those same kind of things that are going to provide continued motivation for the change behavior. In the case of the chips, the change behavior being abstinence. One of the things that to think about when we're talking about reinforcements or reinforcers is that we really, really, really want to break it down fairly small. And we're going to talk about in a little bit about things like, when does somebody get the reward? How often do they get the reward, and things like that. So you want to make the goal or the behavior change pretty manageable. Give you an example. One of the things that we used it for was for attending group. Okay. And what we did is, before each, and this is, again, an opioid treatment program, to encourage people to attend group, what we did was, before each group, underneath one of the chairs, we put what was referred to as the golden pass. And whoever sat in that chair, they got the golden pass. And what that meant was that for the next week, they could go to the head of the dosing line, regardless of what time it was, and be medicated. They'd go ahead of everybody else to be medicated. And those of you that have any experience working with folks in an opioid treatment program can imagine the natives were not really happy with that. But it provided the opportunity to share. It's like, well, if you talk to your counselor about getting into group, you stand a chance of getting one of these too. It's your choice. You stand just as much a chance as anybody else, but you got to get engaged in group. So there was that incentive, as opposed to forcing them to, providing. And it was actually, it was because, needless to say, we keep the door to the group room shut, so that nobody could sneak in there and look where they were sitting. And the first person in would be the counselors, to make sure that nobody flipped the chairs back and looked. But again, the attendance at groups markedly increased. Okay. A lot of times people get confused about motivational incentives and motivational in interviewing. And what you need to understand is both of them deal with ambivalence. Okay. And it's of course, motivational interviewing has to do with the cost and or benefit of maintaining the status quo. Incentives has to do with the cost and benefit of change on the part of the person, the patient. Okay. This is the study that it was the MIDAR MIDAR study, which um, beats the crap out of me. I can never remember what that stood for at the time. But there were the two arms that I spoke about. And then, of course, which had the treatment as usual plus incentives, and then treatment as usual with no incentives. Okay. And what they discovered was that the people who were part of the incentives had more frequent attendances. And this is with the drug-free section of treatment attendance, and had longer periods of abstinence, continuous abstinence, than the folks who just had treatment as usual. Okay, which I think that's that's a good thing. All right. Now, one of the deals too, again, that they presented more negative drug screens. Now, with respect to the folks in methadone maintenance, what the specific thing that the study looked at was negative drug screens, okay, other than methadone. And again, that was, they had, the treatment as usual. For some, they split up as patients came into services. They split them up into treatment as usual and plus the incentives, and there was a significant difference in the number of negative drug screens that the folks receiving the incentives had. Like I said, after we finished up the study, we used it for other things other than just negative drug screens. And we'll talk about that in a little bit too. Before you get into doing this, there's some things you and your staff, or you and your colleagues, need to decide on. Okay. Whatever the targeted behavior is, it needs to be readily detectable. Okay. By that, what I mean is, we had, yes, primarily we would send our urine drug screens off to be tested. And then, usually within 24 to 48 hours, we'd get the results back. For the study, we had to use the instant drug screens because the goal was we had to look at it, or we wanted to be able to see right then, because it was important when somebody was pre-contemplation that the reward came very close to when the behavior was observed. Okay, that was critical, and even 48 hours was too long. Okay, and the fact that they are provided if the patient demonstrates the changed behavior, that they get a reinforcer right then. Okay. And the deal is too, is that if they don't demonstrate the behavior, say, for example, if they had a positive drug screen, didn't mean that they got punished. All it meant was that they didn't get any reinforcers. Okay. And when we talk about the fishbowl, which we will towards the end, that meant they couldn't draw anything out of the fishbowl, any little tags out of the fishbowl, and they had to wait until their next drug screen. And if it came back positive, then they could go in again. So it wasn't like, they didn't get punished, they just didn't get the reward. Okay. So these are the different parts of, in other words, things that if you're going to implement this, that you need to think about and identify before you actually get into it. Okay. And we'll go over each of these individually. All right. In case y'all hadn't noticed, I am perfectly capable of talking nonstop the entire 90 minutes we're together. So if you do have a question, it's all right to put it in the chat box. So first off, making the decision as far as what is the behavior that y'all want to target. Okay. I'll be honest with you. The things to consider is that what is the behavior that's problematic and in need of change. Okay. How observable is it? How measurable is it? One of the things that the folks they continued to use it in our women's services program after the study was over, that they wanted to get increase the level of attendance, because one of the programs in women's services was a program for women who are pregnant or postpartum. Okay, so they wanted to increase the frequency with which the women actually attended doctor's visits. Okay, but what they figured out was that it was one of those that just having a slip signed could still be a bit dicey. So what they did was the patient made the appointment there with their case manager or their counselor, and then the doctors had the slips. Okay, we worked it out with the doctors so that they had the slips. So the doctor would give, or the receptionist would give at the end of the appointment, would give the patient the slip and brought it back. And of course, we knew who all the doctors were. So it's like a lot of times people come up, well, I want to get them to go to more 12-step meetings. It's like, well, unless a specific meeting and who is going to be chairing that meeting, there's no way that you're going to be able to know for sure that that person actually did attend that meeting and that they attended the whole meeting, as opposed to showing up 10 minutes before the end of the meeting. So it's one of those deals that you have to be fairly, a way of very definitely verifying it. And one of the deals, and it's important to understand that, especially because when you're looking at somebody who's pre-contemplation or contemplation, the bottom line is, that kind of behavior, as far as trying to pull something over, that's what they do. That's a coping skill that they learned a long time ago, and they will continue to use it as long as it works. So part of our challenge is to help them learn different coping mechanisms. Okay. And again, like I mentioned before, whatever you come up with, it needs to initially, at least, be fairly easy to accomplish. Okay. So, like I've mentioned, we used it for when people, during the first 90 days of treatment, when somebody first got on the methadone program, we used it with respect to negative drug screens. Okay. And what the deal was is we would give somebody, because during the first 90 days that somebody is on medication assisted recovery, they had to come every day to be medicated. So at least twice during the week, we would ask them to provide a drug screen. Okay. If it was negative, then they got to go to the fishbowl, they got to pull out a slip, and depending on what the slip had on it, that's what they got. Now, the majority of the slips just said, good job, keep doing it, and stuff like that. The thing was that the next time they came in, if they also got a negative drug screen, so in other words, they had 2 in a row, then they could pull 2 slips out of the fishbowl. So the longer the streak ran as far as negative drug screens, the more times they got to pull out. So the chances of them getting a prize, something greater, was increased. Now, if they had a positive drug screen somewhere in that cycle, they just went back to zero and started up again. Um, for folks later on in group, like I mentioned, we we used the free dose or the week free of being able to go to the head of the line as the incentive. Um, so again, those are some things to think about, um, especially when we're talking about choice of the target population. Um, and one of the things to think about, we use, like I said, newly enrolled patients. One of the things we used it for also, and we had tried this about a year before the study, and it didn't work real well because what the deal was is we wanted to provide an incentive to get more people to be tested for HIV. Okay. Um, well, the way we did it the first time was that if they came in to have the test done, they would have their name put in for a raffle, and it was like a month, and there were first, second, and third prizes and all that stuff. Didn't get too many people. The next time we tried it, it was they got a prize if they came in to just have the test done. So again, they made the appointment, they showed up for the test, and once they had the test done, then they could pull out of the fishbowl and stood a chance of getting one of the prizes. Okay. We had probably 3 times more people that had tests done when we did it that way. Um, one of the deals too is, and like I mentioned, the whole issue of the women's services targeting women who are pregnant or postpartum. I've known some opioid treatment programs that was part of the target population. Um, so one of the deals is that this one right here, patients who are not responding to treatment. We'll talk about this some more in a second. But one of the challenges with that population is that whatever the incentive is, if somebody is not making therapeutic progress and is continuing to test positive for whatever the substance is that you're concerned with, you have to come up with an incentive that is going to be sufficient to get them to look at changing their behavior. So if somebody has been, smoking pot for, 30 years and sees nothing wrong with it, in order to, or, misusing benzodiazepines, in order to get them to change, you're going to need to come up with some kind of incentive that's going to cause them to think about it. Okay. One of the things, and we'll talk some more about that when we actually get to the incentives and how you figure that out. But that's something that's real important to think about, because again, one of the deals with SAMHSA's putting a cap on how much you can spend. It's like, I'm sorry, you know, spending with, if you have a cap of $75 per year on how much a patient can receive, you're not going to be able to buy stuff that's really going to be an incentive for that person to stop doing whatever it is that you want to stop them to stop doing. Which, God willing, somebody will hear that up at SAMHSA. The thing is, and this is as far as choice of reinforcer. Oh my God, this is pretty important. I would strongly suggest, if you decide to do this, that you do a focus group with either folks who are not, in other words, say if it's an opioid treatment program, instead of you figuring out what would be beneficial, use a focus group of folks who have been stable in recovery, and negative drug screens for everything other than methadone for ages, um, and talk to them. It's like, what would have motivated you when you first came on? What would have been a motivation for you? What would have been likely to get you to pay attention and maybe motivate you to change? Okay, because a prime example, and this is a program up in North Carolina. They came up with the idea of their reinforcers were healthy snacks. And I got to tell you that, somebody just getting on methadone, a package of carrots is not going to motivate them a whole heck of a lot. Or a bag of granola is not going to be too motivating. So it's one of those deals. You need to ask them from their perspective, what would motivate them? And I hate to put it this way, but I wouldn't suggest doing focus groups with the folks early in recovery, who are your target population, because for a lot of those folks, one of the big motivating factors is for free medication, and that's in certain states that can be a bit dicey. So again, and that's just what the folks at that stage of their recovery do. So it's not a good thing or a bad thing. It's a matter of talking to folks that they're on the other side of that. Okay. Again, these, as far as the choice of reinforcers continued, you can, if you're working at an opioid treatment program, one of the issues is you can give a special take home. Again, but the problem with special take homes is that somebody still has to meet the requirements for getting special take home. What you could, as far as negative drug screens, that kind of stuff, the deal might be that you have to submit a request for an exemption to where you can give that person an extra day of take home, during the week, or an additional level of take home. So that's something to think about. Like I said, we did do, and we had problems. And again, this was for folks early on, because they had their induction physical, and then we took blood for labs, and then they had to come back and sit down with the medical staff and review their labs. And it was like pulling teeth to get them to come back in to go over their lab work with medical staff. So what we did was that they had, from when they were told that their lab results were ready, and they needed to set up an appointment with the medical staff, we gave them a week to set up the appointment during that same week. And actually, we gave them 10 days to set it up, and to schedule it and attend it. In which case they would get it was sort of like we referred to it as a get out of jail free card. It was good for one free day of medication, that they would get after they had the review. If they called to cancel it or to reschedule it, that voided it. So they had to make the appointment, and they had to keep the original appointment. Boom. And then they were eligible for it. So it was one of those things, even if they had a legitimate reason, which sometimes happens, but it's like, nope, you got to make one appointment and keep it. Now this last one here, as far as vouchers or token economies, that you can use this in like a residential program. where somebody can, build up points. The issue is, or you can use this much later on in treatment for somebody, because again, the issue is this is not as immediate. Building up points or whatever is not as immediate as the on-site distribution. So it's like, and part of what we're looking at here, especially for folks early in treatment, is the immediacy of them getting the reward. Okay. So there you go. Now, one of the deals is too, and we'll talk some more about this prize cabinet stuff in a few minutes. One of the deals too is, figuring out what size, what magnitude of incentives are you going to use. This is why one of the deals that I liked about the fishbowl method, because it was, and we'll see it in a little bit. There was a lot of just good job, really great job, as opposed to actual physical rewards. So it was, it wasn't as costly. Okay. One of the deals too is, again, how often are you going to give them the rewards? I had a colleague, and what he did with, he had on his desk, and he worked with adolescent males, and he had a bowl of really good candy on his desk. I mean, we're not talking those 5-pound bags of peppermint stuff that they got at Costco. We're talking really, really good chocolate. And if the patient was on time for their appointment, they got a piece of chocolate, okay, when they showed up for the appointment. So again, immediately when they engaged in the desired behavior, boom. And he said, at first he thought, but boy, one time he forgot. It's like, hey, how come I don't get my candy? And also it was like, okay, there we go. How are you going to distribute the incentives? And how often are you going to do it? Okay. And again, we'll talk about the specific, how we use the prize cabinet. One of the deals we talked about is, especially early on, it needs to be immediate, because again, like I said, doing it once a week, or sending off the urine drug screens, for testing someplace else, it's not going to have the impact. Okay, it is not going to have the impact. Then you need to look at how long you're going to do it. How long is the duration? And what you need to think about when you're figuring that out is, you want to do it long enough to where the person internalizes the changed behavior. Okay, to where the behavior will sustain itself after you stop with the incentives. Okay, that's the goal. Okay, that's the important thing. And so, each one is going to be different, depending on where the person is at in treatment, that kind of stuff. You don't want to continue doing it after, the behavior, after it's already reinforced. So, it's a matter of discussing that among staff and figuring that out. All right. Some other things to think about, what the fishbowl method is. And if you are interested, I've got a couple of research articles based on this particular fishbowl method, that actually this doctor published. If you send me an email and just put contingency management research studies in the title line, I'll be more than happy to forward them to you. But please don't put in the chat box, could you send me, because I'll be totally honest with you. I have age-related attention deficit disorder, which means I can remember 1975 like it was yesterday, but I cannot remember what I had for breakfast on Monday. So the bottom line is, the way this works is that you have this fishbowl, and in the fishbowl you have all of these different slips that are folded over, that have the different level of prizes. And basically, when the patient engages in the changed behavior, they get to draw something out of the fishbowl. Depending on what the slip is that they draw out, then they got to go to the prize cabinet. Now, the way we had it set up was our prize cabinet was right in the lobby. So when the patient who got to go into the prize cabinet, when we opened the door, all the other patients who were in the dispensing line got to see what kind of goodies they got. So again, it was one of those deals that it served as an incentive for the changed behavior. Okay. Um, and this is an idea. And again, this is from 2005. You can come up. And again, towards the end of when I was there, we increased the cost of the small rewards between um, um, $5 and $15. The large awards, we increased them from 20 up to they started at 20 and they went up to 35. So again, but you can see the different numbers of those things as a total percentage. And again, the jumbo ones, give you an example. In women's services, one of the jumbos was a really nice baby stroller. Okay, so it was a biggie. So you can figure out, depending on how much money you have, how you want to split this up. Again, but obviously you want to have, I would suggest that the majority of the things be that, good job, keep coming back, bless your heart. Um, that's one of the things that I just absolutely love about being from the South is that bless your heart phrase. And it's so funny that people that are not from the South, they think that's actually a compliment. When somebody says, bless your heart. So it's like, the deal is you can say whatever you want with, as long as you follow it with bless her heart. Bless her heart, she really needs to see an orthodontist. She could eat corn through a picket fence with those teeth of hers, bless her heart. And for those of you that might be wondering what the 12-step equivalent of bless your heart is, it's keep coming back. Now, something to think about is, again, with the fishbowl method, is that every time they had a negative drug screen, the number of draws would increase. Okay. And when they had a positive drug screen, they would go back to 0. But they'd start over again with respect to the next negative drug screen they had. Now, something to think about is you can also use what we did to sort of augment the prize closet was that we got folks to and places to donate gift cards. We got staff to donate slightly used things to where, the cost was lower. And also it increased, now granted, it depended on what the staff member wanted to donate. I mean, obviously, if it had been like an electric typewriter or something like that, we wouldn't have accepted that because the majority of the patients had no idea what it was. Okay. The thing to think about are these things right here. We've talked about several times: cost of incentives, on-site testing, and the cost of that, and clinical staff's resistance. When we talked about that early on. One of the deals too is, it's looking at it. These are some challenges. I mean, we know this. again, for God's sake, don't give the folks cash, but you can give them like a gas card or a grocery store gift card or something like that, which is there a chance that they could trade that to somebody else for cash? Sure. But it's not as bad as giving them cash up front. Okay. Looking at it, as far as how much you want to, and this is where you'd set up the percentages, how much you want to cap the amount of prize that they can win. The deal too is that the behavior needs to be part of their treatment plan. And something you want to think about is that you don't want to use it for everybody, because using it for everybody, it sort of loses the, I mean, you can have different, criteria for different groups of patients throughout their treatment episode, but you don't want to have something going on continuously with them, primarily because it's sort of like any kind of reward that you get all the time. It loses its significance. Okay. Sometimes people ask, it's like, oh my God, does this increase patients' likelihood to become addicted to gambling? And the answer on that one is absolutely not. Not even close. Okay. And right here is the one that I mentioned, why this becomes, if a patient, especially if a patient is getting more and more negative drug screens, the clinical staff gets pretty excited. They do, because again, they're seeing that behavior change. So this whole deal of why are you rewarding them for what they should be doing anyway, it sort of becomes a moot point. It's like they're changing the behavior. So just let's ride with it for a little bit. And this is, I'm going to give you, and this is not a valid website anymore. If you have any questions, I will be more than happy to if you want to give me a call or send me an email, I'll be happy to share with you some insight on how to set up a prize closet. You can also use, again, the question comes up periodically, can you use this with adolescents? Absolutely. Can you use it with folks with co-occurring disorders? Yes, you definitely can. So what I'm wondering is, I think we've got a little bit of time here. Does anybody, what do y'all think about contingency management, about using motivational incentives? Good thing, possibly bad thing? I don't know. This would be the part where someone speaks, by the way.
I'll speak in.
Thank you so much, Linda.
It's good to see you.
I know, it's nice to be seen and not viewed.
But I am now in Charleston, which I think I've seen you since.
Yep.
And am working with adolescents with a substance use program for the school district.
Yep.
And I'm super excited about using this. I'm not quite sure how I'm going to get a fishbowl around, but I like the idea of it. So I'm excited to learn what I did today, and it was very informative. I've been taking notes and I'm looking forward to going back and just talking with some of the students that are in the program and finding out, like you said, with the focus group. I think that's important.
Yeah.
Because we find out even with positive behavior interventions and support, we have a worksheet that we could do with them to find out what they want, because some of them don't want tangible items. They want their name on the board of.
Exactly. And that is
you talking about that.
Yeah. And just to warn you, you probably noticed Isaac Waters. I don't know if you recognize him, but since Isaac is the executive director of Favor Low Country, that's why you don't see me there anymore. But if you have any if anybody else has any questions, like I said, I'll type it in the chat. Some things to be aware of also before we finish up here. Um, First off, if you are interested, or any of your colleagues are interested after you talk to them about this, of how can they find out about it? We have the ATTC network has a 3-hour self-paced course about contingency management. You can either go to the attcnetwork.org centers / Northwest ATTC case management, or you can, and I'll type this in the chat box for you, healtheknowledge.org, which is our learning platform. And be able, it's free. If it happens you want social worker hours or NBCC hours, it costs like $5 a CEU, so it's a good deal. Or the same thing if you would like NADAC hours, it's $5 each. So one of the things that all right, where did Michelle, dearest? Oh, there they are. Shut up. I won't say it again. If y'all look in the chat box, you will see the post event survey that we need you to download and fill out. And I'm going to type in my email address in here in case you want to reach out to me. Okay. Ed Johnson at msm.edu. The website that I was talking about, that, and there are a bunch of other really, really good courses on there. It's healthyknowledge.org. And so again, or there you go. If you got any questions, you can give Michelle a call, or send her an email, and she can remind you, or give you the stuff to those two things that we just typed in. Well, I would very much like to thank y'all for being here today. I enjoyed